So when to go for it? So that is what is the most important thing. Indications, you have to be very clear. Unicompartmental, age less than 60, BMI most important, less than 35, like I just said. AMOA, that's more important. Varus deformity less than 12 degrees, 10 to 12. Fixed flexion deformity less than 5. Again, these are the two things you have to keep in mind. That is correctable varus. We want to see how much is the correctable varus. And intact ACL, like we were discussing about, if there is any changes in the ACL and a bit of laxity, nowadays with the fixed bearing, we should be okay. Range of movements at least 100 degrees, and preferably normal lateral and PFJ. But recently, Oxford have presented a paper about patella not making much of difference. And contraindications, most important, like all of us know, infection, most important. Then inflammatory arthritis in this scenario, bicompartmental or tricompartment OA, crystal fixed deposition, and the other things like fixed flexion deformity, varus deformity. Most important again in this scenario, ligamentous laxity. You have to be careful. And also, if they have any full thickness patella cartilage loss, almost whole of the surface, and previous HTO. What are the advantages? Smaller incision size, less bone removed, and less blood loss, low morbidity, and quicker rehabilitation, back to work, and shorter hospitalization. What are the potential pitfalls you can have? Like most important thing, like we discussed, unless you're trained, don't want to embark. First, initially take some mentorships, and as you're developing, that's good to continue. And things to keep in mind are inferior survivorship, secondary degeneration in the other compartment, patella impingement in earlier implants. Now they are better, and also stress fractures sometimes on the tibia, like Akhil was discussing, and component loose and wear, which we can see in other things. What are the most important things now? You have to be stringent in your investigations. So unfortunately, you have to do more than what is required for a total knee. Scanogram, standing lateral view, and also in Hyderabad, probably you can easily go for MRI because it doesn't cost you much. And I'll show you just quickly. I won't keep you waiting much. So as you can see there, the draping and four finger breadths below the tibia plateau. That's where we're going to put our pins. And on the femoral side, we don't put it in the incision because incision is going to be smaller, just medial to the patellar tendon. So we can use a smaller incision. And in this scenario, the most important thing is now because I use imageless, I take out all the osteophytes before I balance. So that's what we're going to look at now. And also, most important thing, you need to know your burrs and everything. So that's why I said don't embark on knowing too many instruments as well. Stick to one or two initially because each and every step is important. Now, partial knee robotic, I have to go for 5 millimeter burr, not 6 millimeter. Okay, and it's a burr based. So here you can see that we are excising all the medial side soft tissues, including the meniscus. And the most important thing is not to do too much of soft tissue release. So whatever is just required around the osteophytes, exposing the osteophytes to the mid-kernel plane, as you can see. And that's the typical anteromedial OA, as you see there. And likewise, we are discussing just now, important is to educate the patient and also tell them on the table, you can convert it into a total knee. And always have a total knee on the shelf because at least last 100 unis I have done, at least 3 I had to convert to a total. And one was a 45-year-old lady, but I didn't have a choice. Significant medial OA. She also had grade 3 almost in the lateral compartment and some patches. And patella almost grade 4 on medial compartment, on the medial facet of the patella. So I didn't have a choice. So told her on the table itself, like we planned, it was not going as per uni and it's total. And she's very happy now. It's been now 4 years I've done. So these are the things you have to keep in mind. So these are the pins like we have seen in the morning. We don't want to pierce the fourth cortex. As soon as we touch the third cortex, we stop so that it just enters the third cortex and stops there. that prevents the fractures. And always have a trained assistant. You don't have to struggle. So they need to know your steps. Either a doctor or the nurse, doesn't matter much, because it's quite straightforward. So we use the pins like any other robo, and my system is called CORI from Smith& Nephew. So like we discussed, as you can see, the femoral pins, they're a little bit away from the surgical side. So these arrays that we're going to put on should be well visible onto the robo. So make sure there's nothing comes in between. The surgeon and the assistant should be usually be standing on the side of the person. If it is right, onto the right side, and go around your robo on the other side. So this is the tracker pins. So if in case, just in case your pins become loose, at least there is some bony point there that you mark it there with a metal bit, so that if everything goes wrong, at least these are the two savers. So at least if you go back to your tracker, the robo can be reorganized. So these are the pins that we're going to put on, and it starts again telling the robo. You can see in the inside picture in picture that we are looking at the tibia and the femur, and as always, ankle, lateral and medial, and then your hip. So that gives us the HKA axis. And the different devices to make our life easier, like a Z retractor. Some people just put the KY to do that. So here I am doing the hip center. So like we discussed in the morning, better to take out your side support. It will be much easier rather than struggle. Keep redoing. It hardly takes extra 2 minutes. So I'm telling the robo. I mean, frankly speaking, just following the robo, what it's asking me, the range of movements, and that's a Z retractor that you can see. To first I've given the range of movements, and now the stressed range of movement, because your tissues can be lax. So again, you're telling the robo what is the stress range of movement. So the robo can take into account the ligament laxity, so that you can get a perfect, well aligned and well balanced joint. So this is a stressed one. You either use the retractor. Nowadays we are getting the dynamic stressors, digital stressors. Either way, you can see the size of the incision as well, so small. And these are the KY that I use. So it's much easier. You don't want people to crowd over. Much easier with a smaller incision, and it's quite nicely visible. Now we are marking the points. The most no, area where the tibia touches, the anterior part of the tibia, then the most distal most point on the femur, distal femur, and the posterior most. Each robo has their own way. You just have to tell the robo what it wants, and then the center. So the beauty is now you don't have to make a hole in the intermedullary space. That's what we used to do with Oxford. I worked in Oxford as well, and I know how difficult it was when we did the first unicompartmental. You have to be eyeballing 6 things at the same time. The parallelogram and lots of things. Now it is much easier with the micro instruments. Now we have got, I think it's called the microplasty. Yeah, that's the word. Microplasty instrument, much easier. But things are much easier with the robo. You actually, this is much easier than doing a total knee replacement. As you can see, not much exposure, and you don't have to worry about the ligaments. You're just replacing the bone you're excising. So here we're giving the tibia points. This is the most important step we used to dread when we were doing Oxford. How to put and make a cut. So we used to say face the opposite shoulder. Okay, how you want the saw to go, reciprocating saw. It is much easier with the robo, because you just put your stylus and you get on the screen whether you're aligning that or not. If you go a bit more lateral, you're going to cut off the ACL. You go a bit more medial, you're going to leave the implant more onto the medial. And this is the planning. As you can see now, the beauty is you can rotate the implant and also size the implant approximately. We can see the slope we don't want to touch unnecessarily. For at least initial learners, I would say leave it alone. Usually it doesn't matter much, because like I said, it's anteromedial OA. So checking all the areas, medial, lateral, anteroposterior. You want to make sure we don't want any overhang medially. Otherwise that's rubbing on the MCL causing more pain. Now, as you can see on the graph, we can see where it is tight and where it is loose. So based on that, we can make adjustments even before you put your bar. So we want to bring it to almost to the neutral of the graph. And in unis, we don't mind if you have 2 mm laxity on the lateral side in flexion. So that will allow more easier movements of the knee. So you can see there as we are distalizing the femur, you can see we are coming closer to the graph. So once you are nearby the horizontal, so once you are prepared, then you can start executing. I wish I can speed it up a little more. So if you want, you can leave it a little bit tighter. I don't want to touch this because it's going to start from beginning again. That will be a trouble. I think we are stuck there. Anyway, so that's the beauty of that. So you come to the planning. So this is the most important thing. Once you're closer to your horizontal, probably a millimeter. And like I said, 2 mm is acceptable in flexion on the lateral aspect. Okay. So that's what you plan for. And one of the cases. So nicely done. Okay. Right. Thank you very much.